Dear ladies and gentlemen, thank you very much for the invitation to come to Athens. Kalimera, that's pretty much the only thing I know in New Greek. I had 5 years of ancient Greek, but that wouldn't help here either, because we talk about new technologies, of course. So my task was to talk a little bit about the development of minimal invasive mitral valve techniques. As Theo mentioned, I think it's very important that we surgeons also move into more of a less invasive surgical approach. Because we all know sternotomy, and when I was a young resident assisting mitral valve surgery, at that time we were standing sort of to the left side of the surgeon as a third assistant. I was always wondering how people could really see the mitral valve, because you look sort of around the corner, you know, sort of from below, looking at the mitral valve. And you know, sometimes, particularly in a reoperation, it's very difficult to actually access the mitral valve because the left atrial apex is lifted up, so it's difficult to see. So there is also sort of a direct reason why to go into a less invasive approach. So I was lucky in the mid-90s, same as Theo, I was very lucky to do a fellowship, a clinical fellowship at Stanford University, and at that time, one of the chief residents, John Stevens, developed an endovascular bypass system, very provocative at that time, and the main aspect of this was basically an endo-aortic balloon here, occluding the aorta from inside. So if you want to say it's an interventional cross clamp, and supplying also cardioplegia. And so this technique allowed to have a full cardiopulmonary bypass. Okay, we have a... Okay, full cardiopulmonary bypass without basically opening the chest, which allowed basically the initiation of minimal invasive procedures. I went from Stanford to Dresden and later on to Munich, and Fred Moore in Leipzig. Both of us basically started this technique of minimal invasive mitral valve surgery. At that time already we had some 3D visualization with this helmet basically, which provided three-dimensional visualization. In 2013 we changed the technique completely to what Theo was also explaining, to a totally endoscopic technique. Basically getting rid of the chest spreader, just a soft tissue retractor, because the spreading of the ribs causes a lot of pain in the postoperative period, so we wanted to move away from spreading the ribs and getting into a totally endoscopic procedure. And this has been very successfully initiated in 2013, but led to shorter hospitalization time with reduced postoperative pain and early mobilization. Key, I think, in endoscopic mitral valve repair is a three-dimensional endoscopy. Some of the robotic surgeons say that's also a feature of robotic surgery, of course, but it's very important if you repair the mitral valve to have a three-dimensional view because of the depth perception which is necessary if you do neochordae or other issues to repair the mitral valve. So these are the post-operative pictures. Theo has shown you some already. This is the nipple cut for men, and for women it's a small 3 centimeter lateral incision. We also do the uniport technique, so we try to do everything through this little port. And in Germany, actually, this minimal invasive mitral valve surgery has reached now 60% of all mitral valve procedures. Germany is a little bit advanced, but it's not all totally endoscopic, one must honestly say. So this is just a little video showing, this is the nipple cut, as you see here, so the cut around the nipple. Then you go usually through the 4th intercostal space, and then it's percutaneous femoral, arterial, and venous cannulation. I think which is very important. We learned that from our cardiologists. So you don't do a groin incision. Then you put the 3D endoscope in for visualization. Here you see the pericardium. Nicely you see the phrenic nerve. And then you access the mitral valve. Look at the prolapse here, beautiful. The prolapse of the P2 segment. And then you do your endoscopic procedure using loops and the annuloplasty ring at the end, and then you test the valve, and you see also, of course, intraoperative TE, whether you have a competent valve. Okay, we have sort of intermittent darkness here, okay? So, of course, Laurent Carpentier learned us in the mid-80s or early 80s what are the different pathologies. Of course, the most important one we see also here is leaflet prolapse, degenerative mitral valve disease. There are several options to repair a mitral valve using, of course, always annuloplasty. You can use artificial chordae. We follow the principle of Fred Moore, which is more respect rather than resect. So we don't anymore really do the resection procedures, which were very popular in the 90s, but rather move to neochordae implantation for prolapsed leaflets. So the long-term results are excellent. If you look at long-term data, and Laurent Carpentier institution has 25-year data, and you see for posterior prolapse, the reoperation rate is almost 98%, and also the long-term survival does not differ from non-operated control. These are our own data, so we do about 120 of those procedures a year. Very, very low hospital mortality, usually below 1%, and then we have here in Barlow's disease, we have 10-year data of freedom from reoperation of 95 and 97%. That's not isolated P2 prolapse, that is really true Barlow's disease, so you can do this also very well in Barlow's disease. Of course, we also see other pathologies, such as annular dilatation, for example, where you could do an annuloplasty alone, which has been shown by several groups for type 1. And the data are, if they're shown, the data there's not much difference in event-free survival, whether you do an annuloplasty or don't do an annuloplasty. I will come later to a further explanation of those data. I think it's the same as what we heard earlier on in the talk about the MitraClip studies, that it differs according to the size of the ventricle. Like in the MITRA-FR study, if you have a high LVED index, so a very large ventricle, your results will not be as good as if you have not a severely dilated left ventricle. Of course, very common, we have now ischemic heart disease and a restrictive leaflet motion, so type 3B, according to Carpentier. And there is a lot of centers for ischemic mitral valve disease. They replace the valve, and although this particular study, which was published by Danny Goldstein here, showing basically equal survival results, this is the only study I know where mitral valve replacement has the same mortality as mitral valve repair. All other studies we know has a significantly increased mortality after mitral valve replacement. However, regurgitation post mitral valve replacement is of course less than after mitral valve repair. So what's the problem with restrictive leaflet motion? We have a geometric LV distortion, we have a reduced leaflet motion, as you can see here, restriction of the leaflet in combination with annular dilatation. So approaching the annulus by itself may be not enough. We have to do more than just looking at the annulus. There are different publications on how to approach ischemic mitral valve disease. So basically the ring and string operation here, caudal cutting, posterior leaflet extension, and our favorite approach is papillary muscle relocation. I think we have to do something to the subvalvular apparatus in order to achieve good and acceptable long-term results. And we do this, as you can see here in this little video, we put Gore-Tex sutures around the papillary muscles, anterior and posterior. Then we externalize these sutures through the ring. And then when we tie the knots here, you can see nicely how you pull up the posterior leaflet. So basically, you get rid of the restriction of the posterior leaflet, and then the level of the annular coaptation is much higher than in the original plane. It's a good way to repair, and you can see it also on the anterior side. You see how nicely the posterior leaflet gets pulled up. So this has excellent results. Also, if you look not only at the data regarding freedom from death, but also at tenting height, tenting area, posterior angle, you see a much better improvement if you combine the annuloplasty with a subvalvular repair. We also did a German prospective multi-center study on this called the Reform trial, which showed excellent results in different German mitral valve centers using this subvalvular technique. You can also, I think Theo also mentioned, you can combine it with other procedures, such as procedures on the tricuspid valve. This can also very well be approached in a minimally invasive fashion. And we learned, it's also in the guidelines now, that if you have a severely dilated annulus, this is the CTS-NET trial, which was key basically supporting the idea of repairing the tricuspid time at the same time. We had a much better incidence, a much lower incidence of the combined endpoint if we combine mitral valve repair with tricuspid valve repair. And the advantage is you can do it on the beating heart, which is, I think, crucial because you want to avoid an AV block. If you do your tricuspid valve repair on the beating heart, you can immediately see if you create an AV block, and you can remove your suture again, and patient leaves without the necessity of a pacemaker implantation. The other things you can combine the endoscopic surgery is atrial ablation. We've heard a beautiful keynote lecture today about atrial ablation, and kindly the cardiologist also mentioned surgical approaches for atrial ablation. So basically we do this in combination with mitral valve surgery, but we also do surgical endoscopic atrial ablation by its own when it's necessary. You can also very nicely occlude the left atrial appendage, same approach with the atrial clip. Several studies have shown that occlusion of the LA appendage is crucial in avoiding post-operative stroke after any type, basically any type of cardiac surgery. This is the atrial clip being used. So we've seen that slide before of our cardiology friends, which are around the corner, but I must say I always enjoyed working with cardiologists. You learn a lot from them. And there are several studies, of course, now with interventional mitral valve treatment. We were the first ones in Europe, actually, using the commercially available mitral clip in 2007. And we've done, since then, we've done about, we do about 100 of those mitral clip procedures a year. And there's only one study in degenerative mitral valve disease, which was published several years ago, already the Everest trial, showing basically a better freedom from regurgitation after surgery, but a higher incidence of side effects, which was mainly a higher incidence of blood transfusions. So a study is at the moment basically on the run, called the primary study, which is a randomized controlled multi-center study in patients older than 60 years, where TARE is combined, mitral clip is compared with surgical mitral valve repair. So we'll see what the results will show. So far we have studies, up-to-date studies, only with functional mitral valve disease, and we've seen that before, the MITRA-FR study, which did not show any difference. But the COAP trial, I think the COAP trial is a very important trial because it's the only trial ever showing a survival advantage if you address functional mitral valve regurgitation. We've never been able to show that in surgery, probably because our patient numbers were too low. What's the difference? The difference, it was shown before that the MITRA-FR trial was probably done in the wrong patient population. patients suffering from severely dilated ventricles and severe heart failure rather than from a functional mitral valve regurgitation, whilst COAP trial addressed a better population, and of course the COAP trial, such as the Reshape trial, which was now presented at the ESC Congress, showed favorable results. We also were part of this multi-center trial, which was just presented actually at the ESC Congress and published in the New England Journal of Medicine, the Matterhorn trial comparing mitral clip and surgery for mitral valve disease. And you see that there was no survival difference whether you use surgery or a clip for functional mitral valve FR, of course, with regard to major adverse events such as bleeding, stroke. The mitral clip was superior. However, if you look at the echo data, of course, you get better results with a higher incidence of mitral valve regurg type 0 after surgery compared to interventional treatment. New York Heart Class improvement was about the same in both groups. So, what should not happen in my eyes is that you have this rapid increase and decrease of mitral valve surgery. I think mitral clip therapy is a great add-on to surgical therapy, but in America, unfortunately, I think nobody cares. And we have to do a better job in Europe. So, in conclusion, the heart team will decide the treatment of each patient considering individual clinical, anatomical, and procedural characteristics. And that's the nice thing, like in the newly founded International Heart Center, cardiologists and cardiac surgery work closely together, as you heard today in the presentations. They discuss the patients and then discuss the right approach. Minimal invasive access, and I'm fully online with Theo Kofidis here, that should be used for isolated mitral valve surgery only. TEER for mitral valve, for primary mitral regurgitation should be considered in high surgical risk patients. So we'll see what the primary results show. But I'm also fully convinced that all patients with secondary functional MR should be discussed in the heart team, and there definitely the mitral clip approach has its place. So with this in mind, I want to thank, I remember many visits in Singapore, and I also learned a lot during these visits and had a great time. I wish Theo and his colleagues all the best in the newly founded International Heart Center here in Athens, and I want to thank you very much. Ευχαριστώ.
Thank you very much, Herman, for this great talk and great survey over mitral valve surgery, minimal invasive mitral valve surgery. Any questions from the audience? Κάποιες ερωτήσεις από το κοινό? Herman, let me be slightly provocative and ask following. You are one of the 2 or 3, I don't know exactly how history written itself, pioneers of robotic heart surgery. That ties very well with one of the next presentations. There is this notion going around that one day Professor Freddie Moore stopped robotic heart surgery in Germany and everybody else followed. Can you give us your historical insight and what you truly believe will be the future? Tie very well with the next one of the next presentations.
That's right, yeah, it's good. And it takes maybe a little bit discussion already ahead of the next presentation. No, just kidding. I think I was always fascinated by robotic cardiac surgery. We started in '99 using a different robot called the Zeus system at that time, and Fred started with the intuitive system in Leipzig. And we were very enthusiastic. First, it was really a true three-dimensional approach. When you looked through this visualization component of the intuitive, it was truly three-dimensional. We were fascinated. The other fascination about robotic surgery is that the instruments at the end have a wrist, which can move around like this. My personal opinion is, and we've done mitral valve surgery using this system for quite a few years, I think for what I showed you today, for endoscopic mitral valve surgery, we use a uniport approach, as you do. So one incision with 3 centimeters, that's it. And the other incision where the endoscope is in, we use for the chest drain afterwards. whilst with the Intuiti you need several incisions, of course, also for your instrument. So I think, honestly, for mitral valve surgery, I do not think that is absolutely necessary. You can do it. There's nothing wrong with it. It's expensive, and in Germany, we are sort of in our healthcare system a little bit out of money. So there's always a money issue in Germany. Also, you can do it. But having said that, I'm a great fan of Hussam Balki and the group of surgeons. I know also here in Greece and also in Singapore, I met surgeons who do robotic endoscopic coronary artery surgery. Totally different scenario. I think the endo-wrist at the end of the instruments is very important for doing accurate coronary artery surgery. So I do see a revival of robotic surgery in endoscopic coronary artery surgery.
Thank you very much, Hermann. In the interest of time, I shall thank you one more. We can't thank you enough for gracing our event today. Foti?
Thank you very much, Professor.